Hello, this is Michael Hogue, President of the American Pharmacists Association, and welcome once again to our weekly webinar series addressing the COVID-19 crisis, our open forum for pharmacists to be able to get the latest breaking news as it relates to COVID-19. I'm joining you today from Loma Linda, California, and we are very, very pleased today to have several distinguished guests. But before I get into that, I want to remind you of a couple things. First of all, our webinar today is being recorded and will be posted within 24 hours at pharmacists.com. If you want to follow along with the slides that we're using today, you'll notice over on the right-hand side of your GoToWebinar control panel that there is a link to a PDF file for today's slides, so you can watch along with that. I also want to point out to you that the way we do Q&A in these webinars is that we ask that you type in to the chat box on the side the question that you would like to ask our participants today. And then when we get to the open Q&A section, I will call on your name, and then you'll have 60 seconds to be able to ask your question. The APhA staff will unmute your line so that you can verbally ask your question of whichever one of our panelists today that you wish to ask that question of. So very important that we cover that with you today. And also, as a general reminder, I just want to point out to you that if you joined our webinar today via telephone and not via computer, and you want to speak during the Q&A session, you will need to be sure to type in your audio PIN number, and I would encourage you to just go ahead and do that now. You'll still be muted, but at least then your phone will be active to be able to ask questions. Also, if you do not have the ability to ask questions via audio because you're joining today on your computer, when you ask your question, just type no audio so that I know not to call on you and I'll ask your question for you. Okay, with that, let me just kick off today and give the focus of what we're going to discuss. Today, we thought that it would be really valuable if we discussed what physicians' perspectives were on COVID-19 and how physicians and pharmacists are collaborating together during this crisis. Believe it or not, physicians are encountering a lot of the same things we are, and we thought that it'd be valuable to talk about that. We've got a lot of questions from pharmacists about this topic. And then we're also going to spend some time updating you on some changes to pharmacist and pharmacy practice authorities that are happening at the state level. As you'll recall, last week we had on our show Carmen Catazone, the CEO of NABP, who shared with us some things about state laws. This week we'll have a different perspective and additional information to share with you. Now, I'm pleased to introduce our speakers for today, and I'll tell you who all those folks are, and then we'll get kicked off with our first speaker. We have joining us today Dr. John Kennedy. John is the Chief Medical Officer for the American Medical Group Association, and he's president of the American Medical Group Foundation. He is an endocrinologist by training and was previously serving as an endocrinologist with Geisinger. So very practical practice tips he's going to be giving us today. We're also joined by Rebecca Sneed, the Chief Executive Officer and Executive Vice President for the National Alliance of State Pharmacy Associations. He's going to be able to give us some really interesting, in-depth information about what's going on at the state level. And just like our previous weeks, we are so fortunate to have with us two of our key staff members from APhA, Elisa Bernstein, who's Senior Vice President of Pharmacy and Government Affairs at APhA, having had a 30-year career at the FDA, and Daniel Zlot, the Vice President for Professional Education and Resources at APhA, again, having joined our staff at APhA following a long career with the NIH. So our format for today, we've done these introductions. We're going to start out with about a 10-minute discussion with Dr. Kennedy. talk with him about the physician perspective, and then we're going to switch over and talk to Dr. Sneed for a period of time, and then we'll have open comments. Now remember, use that chat box, and as you have your questions, go ahead and enter them in so we can get them in the queue and be able to answer them. Dr. Kennedy, thank you for joining us today. We appreciate you taking time to be here.
Thank you very much. I'm honored to have this opportunity to contribute the physician perspective.
Great. Well, can you just start out by briefly sharing with us how COVID-19 and the pandemic is really impacting physicians?
Yeah, so we've run out of superlatives to describe the impact. We've settled on probably the fact that the impact has been unprecedented. It's also really highly variable depending on your geographic location, whether you're hospital or clinic based, and whether you're in primary care or a specialty. I think the popular press has done a good job really highlighting the impact on the hospital-based practices, with the pre-surge hospital volumes down to 60 to 70% with the cancellation of all these elective procedures. Meanwhile, if you're in a surge area, you're over capacity and trying to rapidly convert as many of your hospital beds to function as ICUs with negative pressure rooms and the ability to do ventilatory management. But I think maybe missed in this is the impact on the clinic physician. They're seeing 50 to 70% or greater declines throughout the month of March and into April in their outpatient visit volumes, with no elective procedures in the outpatient surgery center. Revenue is down more than 50% in many of our independent group practice sites, forcing closures, staff furloughs, and physician salary reductions. So all these transformations are occurring while the groups are setting up outpatient diagnostic testing centers and special respiratory sites and chronic care locations. So this is forcing staff into new roles and being redeployed to meet these needs, all the while occurring in new sites, often with the physician practicing from home, reaching out to a patient at home, which is a whole new paradigm for medical practice.
Wow, that's a really interesting thing. You know, I don't think that most of us think about physicians being furloughed in a pandemic environment. That's a concept that I think many of us had not really thought about. So the economic pressures, it sounds like, and the practice pressures on physicians, especially community-based outpatient physicians, is pretty dramatic.
It is. And I think the one bright spot in this is the emergence of telemedicine, in that this has been an area that physicians have been able to maintain contact with their patients, whether they're COVID diagnosed and needing monitoring, or the chronic sick patients that have a high level of fear to come in to see the physicians in their practice office.
So telemedicine is something that's really being discussed a lot now, and it's especially impacting pharmacy. We've got pharmacists, of course, who are doing chronic disease management, medication therapy management, all kinds of clinical services on the inpatient and outpatient side. And nationally, there's been a lot of reluctance to allow pharmacists to use telemedicine and get paid for those visits, which is a little different. But let's talk about telemedicine and how that changes or has changed the dynamic of communication between physicians and pharmacists. What's your perspective on that? I mean, is telemedicine potentially a facilitator of communication, or does it create new barriers for physician-pharmacist communication that we need to be aware of?
Well, I'd say that nothing is routine anymore. With the physician and the patient being displaced from that exam room, routine activities such as medication reconciliation, medication allergy and drug intolerances, drug-drug interactions, routine lab work for vital signs and monitoring for drug levels, none of that workflow is occurring the same way that physicians are used to occurring in their practices, with their receptionists, with their medical assistants, and with their rooming nurses, all being eliminated from that workflow. There is a major impact of this shift to telemedicine on many of the key opportunities for pharmacists to improve quality and safety of care.
Okay, well, I tell you what, telemedicine is going to change our lives. I'm guessing it's going to be a permanent change. I don't know that we'll ever go back to doing things the same way. What would you suggest, John, that pharmacists in the community do to better collaborate with community physicians in this area? Are there some tips you would give us in terms of things we should be doing to communicate better with physicians in this world of telemedicine and closed offices?
Sure. I would say, be aware of the ongoing circumstances of your existing physician relationships and the fact that that might change. Physicians may have closed their practice sites or dedicated certain practice sites to be respiratory only for COVID-19 patients, and then shifting their other patients to distant sites for well patient visits, routine vaccinations, or routine chronic care for patients without respiratory complaints. This may mean that patients are no longer seeing their regular provider in the clinic, and that provider may not have that same longitudinal relationship with those patients. So being aware of that and being extra careful about any prescriptions or contact or communications that you receive, and making sure that's bi-directional, I think is very critical during this time.
Well, it kind of leads me into a question about therapeutic interchange and refills, and we'll talk with Becky Sneed about this a little later in terms of state laws, but there's a lot of conversation right now about utilizing the skills and abilities of pharmacists to be able to do therapeutic interchange and to extend refill authorization, since it's so difficult right now to reach a physician or talk to a physician in their office. What are your thoughts about that?
My own personal opinion about this is that therapeutic interchange has been a routine part of hospital care for most inpatient pharmacists for a long time. I know during my experience at Geisinger, anybody that came into the hospital underwent essentially a therapeutic interchange onto the hospital formulary with the medications that are available to those patients. Now I think this COVID crisis really represents a unique opportunity for outpatient pharmacists to demonstrate that same effectiveness and value of therapeutic interchange to their physician outpatient colleagues and state regulators, particularly as we experience supply chain disruptions and shortages of critical medicines, and recognizing the communication challenge that we highlighted above.
Yeah. Well, there are definitely a lot of challenges, and I think the complexities of those challenges as it relates to pharmacists and physicians providing interprofessional team-based care, those challenges are even greater today too, and I think that's illustrated through what you just described. Now, I want to shift gears with you just a moment. As you are aware, last week, the Department of Health and Human Services issued a guidance that authorizes pharmacists to do COVID-19 testing as allowed for under state law. So we'll talk a little bit about that again with Becky Sneed later. But let's say that a community pharmacist is doing COVID-19 testing. We'll say we've gotten to that point that that's happening, and a pharmacist gets a positive test for COVID-19. As a physician, what in the world is that pharmacist going to do with a positive test? What would be the process? And in your mind as a physician, how do we maintain continuity of care?
Well, this is a very real likelihood in this arena. So when you enter in the field of diagnostic testing, you have to have the workflows set up in order to know what to do with that positive result when it occurs. Last night we just had a similar national webinar with all of our chief medical officers. And from the Summit Medical Group in New Jersey, we heard that they now have 20,000 positive test results in their patient population. That's one medical group in North Jersey and the Long Island epicenter. So having these protocols in place in advance is really critical. And in this case, you want to make sure that the patient, you can close the loop with the patient on that results, as some of these results may not come back for 24 hours or longer in several days in certain cases. You also want to know what that patient's primary care physician is or their prescribing physician, and make sure that they're aware of the results. And then thirdly, you may be subject to public health reporting requirements, and the patient may require follow-up by the public health officials for home care rules and also testing of first and secondary contacts. So just like you have a close the loop on vaccinations, on diabetes education, and other services such as anticoagulation that you may be providing, have those workflows in advance, because when this hits, it comes in, as Governor Cuomo says, not like a freight train, but like an express train.
Right. Well, I would also suspect that there would be some sort of need for pharmacists to also report to local public health authorities, correct?
Absolutely. Yeah. If you're taking on the role of a diagnostic test, then you would be subject to the public health reporting requirements and to notify the appropriate primary care or physician as well.
Okay. Well, let me ask you this question about, we have a lot of pharmacists that are in very rural areas or very urban areas and may not be connected to group medical practices such as those that your organization normally represents. How would a pharmacist that's practicing in a remote setting or a setting that's not connected to a group practice be able to effectively collaborate on COVID care or care of chronic conditions during the COVID crisis? What are your thoughts about that?
You know, when I think about this, I do think back to my practice at Geisinger, which is a large rural health provider. And yes, we employed our own pharmacists, but certainly at the outskirts of the network, you know, there were lots of independent pharmacists that would relate to the Geisinger health system. And I think the key in these cases is that they always found a way to provide a unique service that distinguished them from the other larger chain pharmacies. Drive-through windows, curbside pickups, home delivery, perhaps even using a Uber driver instead of your own staff. The ability to do the 90-day refills, pillbox and packaging. You know, in Danville, our Danville pharmacy, they specialized in including medications for your pets when they refilled your medications. What a great service. So I think, you know, come up with something unique that distinguishes you. And then now is the time to reach out to your contacts at the medical groups and go straight to the top. Go to your pharmacy colleagues that are employed, go to the chief medical officer and the head of medicine, and really talk to them about what distinguishes your services and why they should have that bi-directional communication with your pharmacy.
That's great. Well, John, thank you for joining us. We may have some questions for you, but I'm going to now shift over to our second guest today, Becky Sneed. Becky, thanks for you joining us today as well. And we're anxious to be able to hear about the perspectives of state pharmacy associations. So, Becky, thank you for being here.
Thank you, Michael, so much. And thank you for APhA for inviting me, and certainly Dr. Kennedy for your insightful remarks. I'm thrilled to be here and ready for your questions.
All right. Well, I think we'll get kicked off. We've seen lots of changes at the state level. We're all aware that change is happening at a rapid fire pace right now. There have been lots of governor's orders, executive orders, and so forth. Are there some key trends that you see happening at the state level related to pharmacists and pharmacist practice authorities?
Absolutely. And Michael, things are changing every day. But the good news is that state pharmacy associations have strong relationships with their state agencies throughout the year. And that's particularly beneficial during this particular time. They've been working tirelessly to make sure that the new and emerging issues that arise are addressed. And yes, often they do need to be settled through a executive order or some administrative process that the state needs to take. A few states, it's important to note, have very broad practice authority and autonomy, but most of them have had to exercise authority under an emergency use. And I would say there hasn't been one significant development because as new and emerging things happen, there are new and emerging needs that that the states and the patients are exhibiting. I think that it's important to note that health professions are regulated at the state level. Therefore, when an authorization or authority is provided at a federal level, if it's not already authorized at the state level, the state must issue a guidance. And a great example would be when the FDA issued guidance on pharmacists compounding hand sanitizer. Once that policy was issued, state boards of pharmacy and some other state agencies had to take action to allow the pharmacists in their stores to compound the hand sanitizer. I have a map. I don't know whether it's showing or not. I don't see it on my screen. But just as an example, there you go. So this gets an idea. There's been guidance in all of the gray states. That certainly doesn't mean that where there's not guidance, the pharmacists aren't able to do it. They may already otherwise have the authority to, or there just hasn't been an official declaration. But this tells you how quickly the states fall into and provide the guidance necessary so that pharmacists are able to provide the care that they need. Another example that I'll show before you go to the next question is that there's sometimes when therapies that are purported to be beneficial in treatment or prevention but lack good evidence, states will issue guidance or place restrictions on prescribing and dispensing to therapy to try to preserve the drug supply for those that are routinely taken for other conditions, to give the pharmacist the additional support in refusing inappropriate prescriptions for these medications. And this is just an example of what the state activity has been around hydroxychloroquine, chloroquine, and azithromycin.
Okay, well, certainly a time with a lot of change. How are pharmacists at the state level, Becky, being empowered to find alternative therapies for patients whose medications are on drug shortages? John talked about this just a little bit, but I'm interested in what's happening at the state level to empower pharmacists.
Well, you know, when I stated earlier that there probably isn't one most significant thing, this really exemplifies the training and expertise of the medication expert. States that do not already have authority are authorizing pharmacists to do therapeutic interchange to meet patients' needs when there is drug shortages. I also want to clarify, we're not talking about generic substitution. We're talking about pharmacists being able to switch medications within a therapeutic drug class. A great basic example that I think everybody can relate to is albuterol inhalers. Very, very critical to have available in this need when we have hotspots. It quickly has become in very, very short supply. And, you know, as you know, and no disrespect, but there's a little bit quirky with albuterol inhalers because there are 3 different non-AB rated products for albuterol inhalers. And it's primarily because the devices vary, but the medication is the same. So if an order is written using a trade name, technically, if it's not available or the generic's not available, a pharmacist has to obtain authorization from the prescriber to substitute. So and when they do, whether it's something as simple as albuterol inhaler or other more complex drugs within a therapeutic class, it really underscores the comment that Dr. Kennedy made about the pharmacist having access and being able to document in the patient's EHR. You know, the whole team needs to know when pharmacists are doing these items, but the traditional communication pathways are not sometimes going to be as accessible as they previously were.
Okay, well, let me shift gears just a little bit. I also want to ask you about COVID-19 testing. So we've already discussed that HHS made this federal statement about pharmacists being eligible to conduct testing, and we appreciate HHS making this claim, but obviously there's a state level consideration. So what are the states doing to address COVID-19 testing, and what advice do you have for pharmacists about COVID-19 testing from a state level perspective?
Yeah, I think that we're getting new information every day. I think that the guidance from HHS was a tremendous support for the profession, but as you mentioned, we do in many of the states need to have an explicit authorization from the state for pharmacists to be able to order and conduct those tests. And certainly I would urge every pharmacist out there, or every pharmacy that's able to, if they don't already have a CLIA waiver, go ahead and apply for your CLIA waiver now, because this is going to be essential for a lot of the emerging tests that are out there. And I think, it also brings into the question of accessibility to have personal protective equipment. Pharmacists are the most accessible healthcare provider, but often they're in the last line for PPE. So not only during testing, we really need to advocate for our profession to be able to have access to appropriate PPE when providing patient care services.
Yeah. Well, I'm going to ask you one last question, and then we're going to move to our open Q&A period with our participants. My last question I want to ask you today is related to the future. How do you think COVID-19 and what we're experiencing with the pandemic may have a lasting impact on our profession? Is there going to be, there's lots of stuff, lots of policies that are changing. Do you think these things are going to stick long-term beyond COVID-19? And if so, what is your crystal ball telling you in terms of the most sticky of all of the policies that might change?
I think that many of the things that we've been advocating for as a profession to increase access to pharmacist-provided patient care services are really being underscored now. And I think that there will be a forever lasting change. I think that the states are going to see, I think the public is going to see pharmacists being able to provide patient care services that they're going to demand beyond this pandemic. And I think that, as Dr. Kennedy mentioned, our utilization of telehealth and alternative ways of providing care will be everlasting. So, Michael, I agree with you and a comment you made in the introduction. We may not ever go back to healthcare as we knew it, but hopefully we go back, or we progress forward to a healthcare environment where pharmacists as part of the healthcare team can really meet the needs of their communities.
Yeah, I think we all dream of a future where all healthcare professionals, including pharmacists, are empowered to practice as part of integrated healthcare teams and at the top of their license. And so that's what we all hope for. Okay, well, I'm going to ask John Kennedy to join us back here with video. And while he's doing that, we have a polling question for our audience that we would like to ask you all. Is communication with physicians during COVID-19 easier for you, about the same as before the pandemic? Is it harder? Or for those of you who are not in active practice, maybe it's not applicable to your practice. We'd like to find out what your opinions about this are relative to communication. As Dr. Kennedy said, we have had some challenges across the board with being able to have good connective communication. And this is a problem that needs to be solved in the healthcare system, is how we communicate better. So it looks like we're about half of you have voted. Don't be shy, go ahead and vote. Now, many of you who are joining us just via telephone, I know, are not able to vote, so we may not have the ability to get 100% on this. Okay, let's close the poll. Well, it looks like that about a third of you say this is not applicable. About a third of you say it's harder to communicate with the physicians. About 22% say it's the same, and 8% say it's easier. John, let me just ask you very directly. If a pharmacist needs to get in touch with a physician right now, how would they do that? You just mentioned to me that offices are closed. So how are pharmacists going to get in touch with a physician? And staff, we can change back to the slides.
Well, thank you for that feedback, and I think that's something that we definitely need to take back to our AMGA members because that's really important for patient safety and for the quality of care. It is not surprising, given the level of disruption and the closure of sites and the furloughing of staff, that we're experiencing these communication issues. But it's also incumbent upon the medical practices to make sure that the entire care team, from the insured to the pharmacist to the patients themselves, all know how they can reach their providers. There is no substitute, for that one-on-one conversation by phone. That's still the best way. Most of the providers are being set up with their electronic health record access from home, and so the usual communication channels are available through the electronic health record. Also, most of the offices still have their main lines open and will forward the phone calls to the appropriate staff that are covering that physician's in-basket to make sure, that there's timely filling of prescriptions and other near-term requirements. So I think the best way is the old-fashioned way to pick up the phone and reach out. And if there's any issues, to elevate it up the chain to the head of the department and to the chief medical officer or the CEO if necessary, and they will solve that problem very, very quickly as they're adapting to this transformed landscape.
Yeah, great. Okay, well, we're going to open up our lines here and have some questions from our audience. I'm going to call on Lon Lee to ask a question about N95 masks, and I think this question will put to Dan Zlott. Dan should be on the line. Is Lon's line unmuted?
We're trying to find
his line's unmuted.
Okay, we got it.
Okay.
Hi, getting my question. I wanted to know if you knew any way to clean the N95 mask without damaging it, and also what are the ways that definitely will damage it?
Okay, that's a great question. We got to preserve the supply of N95 masks. Dan, can you share with us your thoughts on this?
Yeah, absolutely. Lon, that's a great question, and one that I think everybody is asking right now. And depending on the resources you have available to you, it may not be possible to do. On the other hand, if you're a part of a large health system, you may have some opportunities. So the people have become very creative with how to try to preserve their PPE, in particular N95 masks. The three main approaches that I've seen people using, and again, this is in a large institutional setting. I would not advocate doing this on your own unless you have some very unusual equipment. Our first, one of the first things that came out was vaporized hydrogen peroxide. And so you put the mask in a container with a special device that vaporizes low concentrations of hydrogen peroxide, and that's able to sterilize the mask. Again, just to be crystal clear, I am not advocating pouring hydrogen peroxide on N95 masks. I'm fairly confident that would destroy them. This is a very specialized piece of equipment that's allowed to do this. Other ways that I've heard about is dry heat sterilization. So this is a lower level of heat that's safe for the masks and has been well studied. Again, it's in a very controlled fashion where they cycle up the temperature, hold it there for a certain period of time, and then cycle it down. And there's strict criteria about how hot or cold the masks are allowed to be. So again, I don't advocate trying to do this at home in an oven or anything like that. And the third way is essentially high exposure to UV. And again, that's all very well, it's tightly controlled in terms of the wavelength of UV light and the exposure time, all that good stuff. So those are things for large institutions, again, who have lots of users of N95 masks. There's also a limit to how many times a mask can be sterilized. So they have interesting ways that they're tracking how many times a mask has been through these sterilization processes. So if you are, for example, a community pharmacist, there's probably not a lot of great options at this point that have been well vetted for sterilizing N95 masks.
Yeah, okay, and I just want to point out also that the CDC does have some information about reusing N95 masks on their website, and so I'd encourage all of you who have questions about reuse of masks and sterilization of masks to also consult the CDC's website. There are some good bits of information that you'll find there about that. Okay, I want to go to Starlin Hayden Gritting for your question. I think this is a question for Dr. Kennedy. The question is, do you think community pharmacists could be beneficial to assist with contact tracing? So we talked about testing. What about contact tracing? That's something that we historically have always said is the responsibility of departments of public health, but do you have any opinions about that, Dr. Kennedy? And Becky, you as well, either.
So I believe that as we move through the 3 phases of this pandemic, starting with phase 1 being pre-surge, and depending on your location, you may not have seen the surge in cases yet. Phase 2 being the surge where you're at the peak, and then eventually we're all going to get this whole country to phase 3, which is post-surge. And at that point, I think you're going to begin to see a major push by public health departments to really focus on contact tracing for both primary and secondary contacts. And that is going to require a new army of public health workers to help manage that in order to bring the economy back to full speed and safely bring people back to work and back to normal life. So I think at this point, it's probably out of scope for most physicians, nurses, or pharmacists to do anything more than reporting. But I think as we get into this new world order that's going to follow, there may be opportunities for people to contribute to that public health requirement.
Well, we have a pharmacist on the line who had a comment about this. Meredith Goodwin, we're going to unmute your line and let you make your comment here. It's not a question, but a comment. Meredith? What Meredith is sharing with us is that she's actually volunteering for a board of health, and she's calling patients and contacts as a part of her work. So that's great feedback to have, to know that that's happening. Now, I want to get some clarification here. We've got a pharmacist who's not able to connect to audio, who wants some clarification. Becky, I'll ask you to answer this question. Should pharmacists stop dispensing hydrochloroquine in the community pharmacy setting? Should hydrochloroquine only be reserved for hospital settings because some states are placing restrictions? What do you recommend about that?
So absolutely not. There's not the science to not dispense. I think that the guidance that we've seen from the majority of the states have been to use your professional judgment and to try to make sure that all of our workforce has the appropriate information. You know, hydroxychloroquine is very effectively and historically been used for many, many patients. They need access to that. But then also, if there is a positive diagnosis for a COVID patient and a prescriber orders it, then the pharmacist should fill that if legally authorized in that state. I do realize that there's a couple of states that are outliers that have placed extreme restrictions on the distribution of hydroxychloroquine, chloroquine, as well as azithromycin. But I would say that, you know, you need to use your professional judgment, take care of your patients, take care of your community, but also try to make sure that you address the vast amount of information that's out there that may not be accurate in the use of some treatments and preventative.
Okay. All right. Sandy, I'm sorry, Sandy, I can't pronounce your last name. Tzaferos, Sferos. Sandy Sferos, would you like to ask your question, please?
The line is open.
Hi, can you hear me?
Yes, we can hear you.
Thank you. So my question is, if we are going to be allowed to provide the COVID testing, which testing should we apply for when we're doing the CLIA application?
Okay, that's a great question. I wonder if either Elisa Bernstein or Dan Zlot or both would like to comment on that question.
Michael, in the interim, I'll be glad to take the, and then they can certainly augment my answer. So when you apply for a CLIA waiver, it does not designate which test you are applying to do. It's the conditions of participating with the federal agencies, and if your state has additional regulations that you have to comply with. So it is just the application will allow you to do any CLIA waive test. Pharmacists have been providing CLIA waive tests in many of many years to do cholesterol testing or blood sugar testing. So just think of that as the same type of process. So you will not need to designate which test, and you can imagine there's dozens of tests that are in the pipeline for the FDA to approve that would be available point of care through a CLIA waiver. So just know that you don't have to designate a particular test.
All right, thank you for that. I'm going to ask us to open the line of Rachel Gray. Rachel has a question about DEA and wholesale transaction limits, and that's a question I think for Becky or someone else on our government affairs team.
Can you hear me?
Yeah, we can hear you. Please
Perfect.
go ahead.
So I see that the DEA lifted their 5% rule as far as casual sale or wholesale transactions, but Colorado, which is actually, I believe, under statute, not necessarily in board law, I don't see any waiver for 10%, but have we seen anything, because we have some instability in the market with lifting these limits so we are able to sell medication between pharmacies?
Becky, any comment on that?
Yeah, I think that that's absolutely the right path, and one in which many of the states, if there's explicit restrictions that they're trying to alleviate, to allow those transactions to occur. So I think that Colorado's leading the way, but many states can probably also do the same or similar things, and we should, make sure that we advocate if there are any barriers for pharmacists and pharmacies to be able to do that.
Okay. We received a comment from Laura Hall, who's unable to use her audio, but she's pointing out, I think, Dr. Kennedy, for your knowledge and benefit, that in Westchester County, New York, it's very difficult to reach a physician, and they would really appreciate physicians calling back in a timely manner, even if they're not in the office. Apparently, physicians are sometimes not checking voicemail when pharmacists are leaving messages. There's a delay, significant delay. So I suppose that's another piece of feedback maybe to take back to the members.
Thank you, and that makes sense that there would be the most difficulty in Westchester County, as many may be aware of the issues that occurred in New Rochelle, and how that truly was, the first epicenter of the outbreak, throughout the whole New York metro region. So the physicians that I talked to on the ground there are, their outpatient clinics are closed, their voicemails probably are not working. And so I would recommend reaching them through the hospital and through a paging system and other mechanisms. And I would not leave voicemails in an area of a epicenter.
Yeah, okay, that's good feedback. I want to call on Amanda Applegate. She's got some great comments here about CLIA testing and follow-up to Becky's response. This will be good feedback for, I think, all of us to receive. Amanda, are we able to get your line open?
Yeah, yeah, absolutely. So we have pharmacies in both the state of Kansas and the state of Missouri. And we had already gone ahead and put in CLIA waiver applications for both states. And the state of Kansas did specifically reject our application with the COVID testing listed on there, telling us that we needed to have specific tests on the waiver before they would actually go ahead and process it. So they said we can update the waiver at a later date, but we were rejected with just the listing of that, even though He said that's what the CMS application has on it, but we're told that it would not be accepted.
That's good
Yeah,
feedback.
Michael, I've heard that as well, and particularly when states have authority on top of what the federal government has. So I just stand corrected on my assertion that you don't need to put which test on there, because some states do have requirements that you do list which tests you're going to be administering, and so I always am looking for a solution, and I'm like, you can use your CLIA waiver for a lot of tests that are not COVID related. And so if you can amend your waiver with your state at any time, go ahead and submit it with things that are routinely available and have been available for many, many years. And then when specific tests are available, you can amend your waiver.
Okay. Adam Salas has a question, and I'm going to ask APHA staff member Mitch Rotholtz to answer Adam's question. Adam, would you like to ask your question?
Michael, he doesn't have a pin. Like he's
I apologize. Yes, I see that. It says no audio. My apologies, but Mitch, I'm going to ask you to answer this question. Are there any discussions or concerns about flu immunizations for the next flu season, 2021, with availability or recommendations allowing for immunizations again? Maybe you could just clarify for us, Mitch, what is the CDC saying about routine adult immunizations right now, since pharmacists do quite a number of those? And then what do you predict is going to happen with flu season next year?
I wish I had that crystal ball to give definitive, but I'll give you, at least from what we know from the discussions we've been involved in. First of all, CDC just updated its website for pharmacists and pharmacies. And I refer folks to look at that. But basically, in regards to immunizations, CDC's recommendation is to postpone routine immunizations for adults, and to utilize benefit versus risk. If you're doing a service for a patient and the benefit is for them to get vaccinated and you're comfortable, they're comfortable doing it, there's no prohibition on that. But the preference is for you to postpone routine immunizations at this point. There are a lot of discussions that are underway talking about the upcoming flu season, and really not trying to set hard dates in, but looking at milestones. But as things occur in the environment with COVID, what may or may not happen. And so there's a lot of what ifs being talked about. But right now, planning is that we are going to have flu vaccine available for the flu season. At the end of May, we'll get an update from manufacturers to see how production is going. We're also looking at having discussions about how much additional flu vaccine might be available in the coming season, because there's going to be an increased want and desire for individuals to do things that they themselves can do to protect themselves against future public health issues. And so vaccines is a good way that somebody can help protect themselves by being up to date on immunizations. At the same time, we're talking about the flu season. We're also talking about when the COVID vaccine is available, what's going to be happening. And so bottom line is plans are underway for the upcoming flu season. When vaccine is available and when it should be started to be vaccinated is still undetermined based upon what's going on in the environment.
Yeah. And Mitch, as you know, the most frequent question that we've received on these webinars over the several weeks that we've done these now is always related to personal protective equipment. We have more questions about PPE than any other subject, and so that's why we try to do a little bit of coverage every week about PPE. Can you tell us what the CDC's guidance is, and just real quickly, maybe in a minute or less, about what the CDC's guidance is for pharmacies and personal protective equipment?
Well, the update that was just put up on the website talks about both the individuals coming into pharmacies as well as pharmacists and pharmacy personnel wearing masks. For the pharmacy and pharmacy personnel, it's not a cloth mask, but it's a mask that's It doesn't specifically say an N95, but it says a mask, but not a cloth mask. So I think that's the guidance there. Still, we encourage individuals who are doing any hands-on procedures, be it immunizations or others, wearing gloves should be done as well. And then the cleaning and protection. Again, it's a comfort level of the individual who's being asked to provide the immunization as well as the patient.
Yeah, and one last question about all of this that's been posed to us is OSHA guidelines. In a normal situation, OSHA says that employers are supposed to provide training on the use of PPE to their employees. If pharmacist employers are listening to today's call, do they need to comply with OSHA guidelines, and how would they find out if they needed to comply with OSHA guidelines for training relative to PPE?
Well, OSHA's, their guidelines, and that's the answer every time we've reached out to OSHA, and OSHA again just put some updated information based upon some communication that APhA and others have sent to them asking for some more definitive guidance. I would recommend to all employers to follow as best they can the OSHA guidelines for protection, because that's what they're there for, it's to protect the individual healthcare worker.
Okay, I'm going to give Shelley Spiro the last word. Shelley, we're going to let you ask your question to Becky Sneed, and then we'll share some additional information with our participants.
Trying to open her line, but there she goes. Shelley, you're on.
Thank you, and thank you for hosting this great discussion. My question is for Becky Sneed. Once a COVID-19 vaccine is available, do any state boards of pharmacy have to change their regulations for pharmacists to order and administer the vaccine similar to the flu vaccine? If so, which states, and is there action already taking place?
The answer is yes to all of those questions, Shelley. We anticipate when the vaccine is available, it will, of course, be an FDA-approved vaccine, but it will not have gone through the ACIP process yet. Most states require that even if they have broad authority to administer vaccines, that it is according to CDC and ACIP guidelines. So what we are working on now is with our executive offices is really trying to make sure that there is a thoughtful approach to proactively authorizing pharmacists to administer all FDA-approved vaccines during a pandemic. And so that's the process that most states will have to go through, either through their executive orders or if their Board of Pharmacy has the authority to execute those types of orders. But great question, Shelley.
Well, we've gotten so many good questions, and I really wish that we could get to all of them. We've got probably a dozen or maybe 20 more questions that we could take if we had time, but we don't. So John, Becky, thank you both for joining us today. Now, we're going to take our video off, our webcams off, but I have some critically important information, so no one leave the call. We still have a few more things that we want to share with you today that hopefully will be important. On the next slide, we want to let you know that there are 2 new episodes of APHA's 15 on COVID-19. And if you're unfamiliar with this, APhA has been releasing every week new CE modules that are about 15 to 20 minutes long, and you get a 15 minutes worth of CE for going through these webinars, and it's on cutting edge information on COVID-19. We have one related to testing and one related to convalescent plasma that have just been released, and there will be a new one tomorrow, an update on treatment that'll be shared with you as well. On the next slide, you need to know that based on feedback from members and feedback we're getting across the country, APhA and other pharmacy organizations had a meeting with the FDA last Friday to discuss drug shortages, to discuss compounding, the supply chain, fraudulent COVID products, hydroxychloroquine, chloroquine issues, and all kinds of new legal authorities for COVID response from the FDA. And so that was a very productive meeting, and we'll look forward to the response from FDA based upon that advocacy work that's been going on with the pharmacy organizations. As Mitch mentioned to you earlier, OSHA also has released more specific guidance related to pharmacists and pharmacies based upon a request that APhA made back on April the 1st. That sounds so long ago in COVID years. But on CDC guidance, we've gotten, as Mitch mentioned, some updated guidance with additional safety information for pharmacists and pharmacies, and we encourage you to visit their website. We are working very closely with Becky and NASPA and looking at other federal ways to reduce the barriers to implementing HHS's issued guidance authorizing licensed pharmacists to do COVID testing. And we're looking at all the things about billing and payment and so much more. And we realize that all of you have questions about all of that. And I can tell you that APhA is working very hard to try to get solutions to all of those challenges so that we can give you concrete information. And as you also may have known, if you noticed on social media, the HEROES Fund has been in the news as of late. This is a bill moving through Congress that would provide some tax relief to heroes in our society. And we did some advocacy with Senator Schumer this last week regarding inclusion of pharmacists as medical professionals in the legislation, and that has been done. So we are excited about that, the pharmacist inclusion. On the next slide, you will see that we have quite a number of resources available for you in our practice resources section. There are new things every single week that are added, and what's listed on the slide today are the new things that have been added since last week. So we have lots of new information, and we encourage you to check it daily because there's something new coming almost every day with COVID-19. Now, one other thing that members have been asking a lot about is the financial considerations. We know that in these particular times, each one of us and the profession are having financial concerns. And I think, as we heard from Dr. Kennedy, that physicians are having those same concerns. We know that there's lots of fear and anxiety about how this COVID crisis is going to impact us as pharmacists. You know, some temporary unemployment, and the markets are declining, and maybe your 401k doesn't look like it did 6 months ago. So we have a webinar with certified financial planner Tim Baker that addresses many of these concerns and questions about how to do investments in this environment of market uncertainty, how to deal with student loan repayment for those of you who are graduating and have issues with that. So we would just point you to pharmacists.com, and you'll find the link here to this financial considerations. We also want to remind you that APhA has a platform, a social platform for pharmacists to be able to engage in conversation regarding COVID-19. We've gotten great feedback and great stories from pharmacists on the Engage platform this last week, and we've also had some really wonderful questions posted. Those questions oftentimes guide us in knowing how best to position these webinars and give you information that's really going to make a difference in your practice. So we encourage you, join us next week, same day, same time, same place for our weekly webinar. It'll be April 23rd, 1 to 2 p.m. Eastern Time. And again, today's recording and slides will be available within 24 hours on pharmacists.com. Thank you so much for all that you do every day in the care of your patients. God bless.